walking by, Bill just said, yeah, show me the money. I'd love to. So I was talking with Frank Nichols and Mark Allen when they said, we've got this last session planned, and we've got some things planned. And we said we'd like Doug Wood to talk about the history, the organization, the structure of the STS to inform the members. I said, well done. I said, Doug, check. And then we'd like Bill Baumgartner to talk to us at the ABTS about maintenance of certification and fill us in on that. Check. And then they said, we know that that'll be somewhat detailed and somewhat dull, and the talks could be somewhat boring. Check. So we would like you to sort of spruce up and sort of end with a bang before lunch, and we'd like you to talk about coding and reimbursement and make it upbeat and entertaining. And I'm going through my list of miracles: water to wine, loaves and fishes, entertaining coding. Sure, I can do that. That's not a problem. And then Frank, just before he came up, said, and keep it to less than 10 minutes. Good luck with that. That's not happening. So we're going to talk about the coding changes for 2013. I have no disclosures. I just wish I did. Remember that with regard to coding and reimbursement, there is no regulation, no rule on who does the CPT coding. We on the coding committee think the optimal coding situation is when the surgeon and the coder work together. It should be an interactive and collaborative process. If they're just doing it from your OR notes, they're going to make some mistakes. If you're doing it and you're not familiar with the bundling edits and the specific modifiers, there are going to be some faulty bills. It really is a collaborative effort, and that gives you the best prospect for compliance, which means they won't throw your ass in jail. And secondly, hopefully, your most favorable reimbursement. This is what we like to call the cycle of reimbursement. Starts with patients coming to you, the surgeon, for an operation. You do the operation, then you have to put down some sort of CPT code, and you're going to work with the coders to do that. Remember, the CPT codes come from the AMA CPT committee, and that gives you the code, but the valuation actually is determined by the AMA RUC, or Relative Update Committee. But they don't actually determine the value, they actually suggest a value to CMS, and CMS is the one that publishes the final rule and then says, this is the value. Insurance companies take that publication and then decide what they're going to pay you and whether or not they're going to cover the patients. It seems a little complex, seems a little abstract. We like to think of it in an upbeat way and say this is the coding circle of trust. I showed this to Cam Wright, and he says, boy, that you can't say that. I said, why? He said, that's way too abstract. I said, well, Cam, I need something that shows how it's all interactive, how motion from any one will disrupt the other, and how essentially it's a large circle where it has to act as a whole. He said, what you need is an illustration. I said, okay. I got an illustration. The coding circle of trust. So, what's the goal with coding? You got to document. Bill, come on, you like that, really? That was as good as the goddamn Baltimore Ravens slide, right? So, anyway, you got to document. You got to have a proof of service. And remember, it's got to be medically necessary. We get some operative reports and say, how do I bill this from some of our members? And you're really looking for the medical necessity. That is part and parcel of Medicare reimbursement. And if it's not medically necessary, and if you do it time and again, you could be in for some trouble. You have to remember the global periods. Most of the things we do are big things with 90-day global periods, so after you operate on them, generally, unless there's something else going on, you can't bill for the routine post-operative care. But some have 0-day globals. We'll talk about those, and you're leaving money on the table. You're losing a billing opportunity if you don't bill for the E&Ms after that. There are bundling edits and modifier usages that really are quite technical, and even those of us on the coding committee sometimes have difficulty with that. That's where working with your coder is really important. And then there are payer rules and regulations, and most of those actually come from CMS. And we've had a difficult relationship with CMS of late. Any relationship that you have between two entities really depends on what your view is of them and what their view is of you. The CMS has a view of the surgeon, and generally we've been a target as of late. Not just us, proceduralists in general, and they're trying to, as you know, move money from procedurally related CPT codes to the cognitive closely related to CPT codes. And surgeons also have a view of CMS, and we feel that they mostly have their heads up their ass. So this is a mutual respect kind of thing, and we've been working with them. There actually have been some difficulties with CMS that we're trying to work out as of late. Now, new CPT codes. This kind of looks like Paul, doesn't it? Yeah, it does. So these are 6 new CPT codes for bronchoscopy and tracheoscopy. There, 31647 is bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed, with balloon occlusion, assessment of air leak, airway sizing, and insertion of bronchial valves. So this is essentially, after the vent trough, the Zephyr, the emphasis, the spiration valves, these are the codes that people will use now for placement of intrabronchial valves, either for the performance of lung volume reduction or to help abate air leaks and the like. And there is also a code 31648 for removal of the bronchial valves. Similarly, it's very rare that you put in a single bronchial valve, especially for lung volume reduction. So there are additional codes, 31649 and 31651. The little crosses in front of them before them show you they are what are called add-on codes. That means you get the full value. Generally, you know, if you do 2 operations that are not related, you get the full value for the first code and about 50% for the second code. Here, you get the full value for each of these. So 31649 is removal of bronchial valves, each additional lobe, and 31651, the same balloon occlusion, assessment of leak, airway sizing, etc., for additional endobronchial valve placement. There is also bronchial thermoplasty. This is, for those of you who are not keeping up with the literature on voodoo bronchoscopy, this is, are all the pulmonologists gone, I hope? No. So this is, if that looks to you a lot like the Stretta catheter the gastroenterologist used to use to try and scar down the GE junctions so that to replace fundoplication, then you're right. It does look a lot like that. But essentially what that's supposed to do is deliver high frequency energy to the submucosal musculature, and it's done in multiple lobes, and it's done for asthma. And the whole idea is that essentially you scar down what otherwise would be contractile musculature, prevent some of the bronchoconstriction, and improve asthma. As you know, pulmonologists have been delivering energy inside the airway for a long time. This is just another form. I'm not certain any of you will be involved in this, but if you are, there is now a code for it. It may be that if you're doing the interventional bronchoscopy in your, and the interventional pulmonology in your hospital, this is something you may be asked to do, so you need to understand that there are now codes for it. 31660, bronchoscopy, rigid or flexible, including fluoroscopic guidance for bronchial thermoplasty, 1 lobe, and then with 2 or more lobes, there are 2 different codes for that. The chest tube code was under attack by CMS. They kept saying that we were being overpaid, and part of that was because with the newer technology that was introduced about 10 years ago with the insertion of the tiny Cook catheters and pigtail catheters, every Tom, Dick, and Harry interventional radiologist and pulmonologist was charging for a chest tube when they were essentially putting an angiocath into the chest cavity. Obviously, a lot less work involved, and so in general, they were being overpaid, and Medicare wanted to decrease the reimbursement significantly for a chest tube, and this is one of those areas where we as a coding committee fought hard for that and said that's inappropriate. What you need to do is just decrease the reimbursement for the smaller catheters, and so that took us some time to develop some new codes. There are now new codes 32554 just for thoracentesis with a needle or catheter without image guidance. With image guidance, it's 32555. And then for pleural drainage, percutaneous, the standard pigtail catheter or Cook catheter people are placing with insertion of an indwelling catheter is 32556, and if you use image guidance for that, it's 32557. So essentially, and it's hard for you to read, I'm sorry, this is, but we're getting paid now 3.29 RVWs, whereas for just to aspirate without imaging or to insert the catheter without imaging, it's 1.82 or 2.5. So they're getting paid less, we're getting paid the same. It's not a big win in terms of we didn't double the reimbursement, but we sure as hell stopped them from cutting it by 20 or 30%. But you should remember now that if you are putting in a pigtail catheter or a thoracentesis catheter, those are the more appropriate codes to use. SBRT or stereotactic radiosurgery, it can be done with a CyberKnife, with a Varian, there are multiple different commercial products, but we worked for 3 years with ASTRO, the Society for Therapeutic Radiation Oncology, to try and get together a code. And finally, we have 32701, which is thoracic target delineation for stereotactic body radiation therapy for the entire course of treatment. You cannot report it with these codes, which are the codes that are there for the standard radiation therapy management and delivery, and fiducial markers are placed under a different set of codes. This is for a distinct procedure, and this is going to be more important. Once again, this morning you've heard all about stage 1A cancer. Is it going to be an operative entity any longer? Are we going to go with radioablation? Are we going to go with SBRT? This is real. This is coming, and we all need to be involved. Can I just get a show of hand? Who here does SBRT? So we've got maybe 10% of the group doing SBRT, and I would suggest you all that, and this is off the coding subject, but yes, there's a code for it, but you ought to be involved in it. At the very least, if you're not doing the contouring, you need to be involved in all the multidisciplinary conferences and the decision, because otherwise this is going to happen. What's going to happen to us is just what happened to the cardiac surgeons when PCI came, and all of a sudden they would not see the patients. An end around would be done, and they never saw the patient with 3-vessel disease and poor LV fraction until they came in with the full metal jacket and 17 stents in place. You will not see this stage 1A cancer until they failed RFA followed by SBRT, and they have an 8-centimeter radiated lesion in their right upper lobe. So we need to be involved in this from the get-go, and this is a good way for us to do it. What we do is, as the surgeon, you identify and help delineate the target for therapy. You actually draw the contours. The radiation oncologist reports the appropriate codes for clinical treatment planning. You're actually doing the contouring and the planning. They take care of the physics and the dosimetry and the delivery and management. And there are a whole set of codes that they use. Target delineation involves specific determination of tumor borders to identify the tumor volume, relationship to adjacent structures, and this is where we're actually better at it than they are. We understand the intrathoracic anatomy. We understand what the difference between the atelectatic lung and where the tumor ends and where the bronchus and artery begins, and that's very important because significant complications can occur if you treat these people inappropriately. And the important thing is this is a one-time only. You only report target delineation once for the entire course of therapy, and it was given a work RVW of 4.18. The total RVW is a 6.55. It's going to be about $220. It honestly only takes about half an hour to an hour of time. But the importance, honestly, is not the amount of money you're getting for that. It's the fact that you are involved in the care and involved in the decision-making. And if you don't get involved in that, once again, the old saying, if you're not at the table, you're on the menu. So you need to be involved in this.
Hey, Keith,
Yeah.
quick question about that.
Yeah.
That does not cut into the fees given to the radiation oncologist?
Absolutely not. They have their own fees. They do quite well. You don't have to feel sorry for them at all. They are all paid better than you are. Guarantee you.
Oh, I know that.
So here's Jim Lukatich next year presenting his next stage of the minimally invasive esophagectomy. We have talked at length about trying to put together a code for minimally invasive esophagectomy. The problem is there certainly is no standardization. Is it thoracoscopy and laparotomy, laparoscopy, thoracoscopy? Is it thoracoscopy hand-assisted, yes, no, neck, chest? Where are you doing the anastomosis? Oh my God, there's just no way to do it. We would not be able to standardize it. Plus, as I said, every time we have encountered recoding and revaluation with CMS in the past 2 or 3 years, they are doing their damnedest to cut us by 10, 20, 25% every time we bring it up. We believe that if we approach them for a code for this at the present time, they will do their best to gut it. Right now, we think the best way to code this is using the unlisted esophageal procedure code 43499, and you ought to bill the same amount you're paid for when the same procedure is performed openly. If that's denied, you can use the appropriate open code, and you can say that your organization, your professional coding organization, suggested that you do that. Coding ideas? So there are some other new procedures that are coming up, as you know, POEM, or the per-oral endoscopic myotomy. It's a endoscopic procedure, a submucosal approach, working underneath the mucosa, trying to ablate or divide the musculature, the lower esophageal sphincter musculature, without any laparoscopic approach. That is currently being taught in multiple courses, but there is currently no code for it. We suggest you use 43499, the unlisted procedure for the esophagus code. It may be that this proves to be a highly effective method that we're all going to use, but in the meantime, that's the only appropriate code for you to bill. You should not bill an open laparoscopic myotomy with partial fundoplication code. That will get you in trouble. And similarly, the link system, you know, this is essentially a magnetized series of, it looks like a pearl bracelet. It's magnetized titanium beads on a central string. These things actually attract and suck together, and when they suck together, when they're wrapped around the lower esophageal sphincter, they close it off. When the esophageal musculature is strong enough, when a peristaltic wave comes down, to push a bolus of food past it, the magnets separate, allow the food to pass, and then close back down. I think it was last week in the New England Journal, they had the first clinical series reported for this. And it is something that may come down the pike. I love the fact that when they reported it, they said, pH, the pH scoring, esophageal acid exposure was either normalized or cut by about 50% in 60 or 70% of patients. I'm not convinced this is going to be the answer. There was no erosion at 3 years so far, but that obviously was a problem with many of the other prostheses, like the angel chick prosthesis. Currently, you cannot bill and should not try to bill for a laparoscopic anti-reflux or fundoplication procedure. That would be fraudulent. The only current code that you should be using is 43289, an unlisted laparoscopic procedure for the esophagus. And coding is going to be carrier priced until this becomes more of a proven procedure and they get their own CPT code. So moving on from there, just some tips to things you remember, because once again, you do not want to leave money on the table. Many thoracic procedures are allowed bilaterally, whether it's thoracentesis with or without a catheter, indwelling pleural catheters, chest tubes, LVRS, thoracic sympathectomy. You bill, if you're doing both sides, you bill for both sides. There is a bilateral procedure modifier that you should use, and you should get paid more. It's not just, I did an LVRS and you bill the one, because if you're doing it bilaterally, you ought to get paid for bilaterally. Other things to remember, once again, I talked a little bit about short global periods. Tracheostomy, bronchs, thoracentesis, chest tubes, pleurodesis, all those have 0-day global periods, and we're sort of used to those. But the ones that people tend to forget are now the diagnostic thoracoscopy codes. Even a diagnostic resection of a biopsy of the pleura or a diagnostic resection of a piece of lung have a 0-day global. So you can now bill, if they're in the ICU and you're giving critical care, you ought to bill critical care codes, and that's for every 31 minutes or greater, that's like 4 RVUs. And if you're not giving critical care and you're just giving them care in the postoperative period until they go home, you ought to be billing those daily E&Ms, because otherwise you're just giving away money. It's true for esophagoscopy. Mediastinoscopy is a 10-day code, and the only one to be careful of, you would think if a mediastinoscopy is a 10-day global, then a Chamberlain would be a 10-day global, but that came out as a 90-day, so it doesn't make sense, but that's the way it is. But just remember, post-op visits can and should be billed as E&M visits, because otherwise you're just not collecting the money you should. Last topic, ICD-10 coding. For everything you've heard, it's probably worse than that. We need to start paying attention to it, because it's coming as October 1st, 2014. The whole idea for ICD-10 is it's supposed to add a greater specificity, laterality, and granularity to the descriptor terms. Remember that the government now believes they're going to save money because of big data. They're going to use the Medicare database and other databases to identify best practices. They will pay for what they consider to be appropriate care, not pay for inefficient care. They will get those answers from their big data, and they believe that in order to get that, they have to have very specific diagnoses for every hospital stay and every procedure you do. So we're going from 17,000 ICD-9 codes to 155,000 ICD-10 codes. There are two parts to it. There's the diagnosis coding, and this is what you have to pay attention to right now. ICD-10 diagnosis coding is coming as of 2014. This PCS code, which is the procedural coding system, is actually for the hospital only. You will not have to be worried about that at present. It could be that someday Medicare will change to that from CBT, but at present, what you're worrying about is ICD-10. So, ICD-10, how bad is it going to be? Well, maybe you'll see somebody who got bit on the chest by some animal. And it's not just enough to say they got bit on the chest by an animal, because now there are, an etiology injury includes 312 different animal choices. You're laughing, this is real, don't laugh. There are 9 codes for turtles, 9 for macaws, but cobras get 12. My own personal, I love the orcas, but really the sea lion codes, those are my personal favorites. 9 codes for sea lion injuries. It's a problem, and it's not just what you got, it's where you got it. You would say, well, workplace, home, that ought to be enough. And that's not enough. Site of injury includes the opera, the art gallery, shops, supermarkets, children's homes, the zoo, theater, and mobile homes. And it's not just the mobile home, there are 9 sites in a mobile home. Now, a mobile home is only about this goddamn big, right? How can it be there? But there's I swear, bedroom, bathroom, living room, dining room, kitchen, garden, and swimming pool. How many mobile homes have a swimming pool and other? There are 9 different sites in a mobile home, and you have to code for the appropriate site that the injury occurred in. And lastly, this is the wonderful one. Lastly, everybody says, "Oh, it's a lie, it's a lie. You can't possibly be telling me the truth." I should you not? There are 21 codes for miscellaneous spacecraft injuries, for injuries incurred in or collision with a spacecraft. You're laughing, this is real. So we have a real job laid out for us here. Now, it's not necessarily going to be as bad for everybody. First of all, there will be supposedly computer programs and coding seminars, and you ought to be able to get to it. It's supposed to be easier than ICD-9. Easier than ICD-9, and the check is in the mail, and I got something to sell you. It's not going to be easier, but for some things, it's actually not that different than ICD-10. These are the esophageal cancer codes. You remember esophageal cancer that we currently is that it's cervical, mid-thoracic, lower esophageal, intra-abdominal. There is a malignant neoplasm of the upper third, the middle third, the lower third, or a big one that overlaps those sites. It can be unspecified. You can have CA in situ or a benign neoplasm in the esophagus, and you say to yourself, well, that's not so bad, right? That's doable. That's absolutely doable. And then you decide, well, what happens when somebody comes in with like an injury to their esophagus? Well, that's where it gets a little tricky. There are 63 different codes for open wounds, lacerations, punctures, contusions, foreign bodies, impacted food, burns, corrosions, unspecified injuries, and aspirated gastric contents. So fortunately, we won't be doing most of that. Maybe the gastroenterologists or the ER docs will be bothered by most of those, but you can see that the level of granularity, the level of specificity is going to be so much that it could be really onerous for us and for our coders. So, but remember, this is the idea that the government has. Big data is going to save their butt. The granularity, they're going to get, their solution is to get better data, and they're going to cut healthcare costs. That's their solution. Remember that thing about the government when they say it. If you think the problems we create are bad, just wait till you see our solutions. So that's coding in a nutshell. Remember that there is an STS coding hotline. Julie Painter is our staff. She is wonderful. Not only is she a very nice person, but she's exceedingly helpful, and if you have coding questions or if your coders have questions, that's the person you ought to call first off, and then unfortunately they call Frank and bother him, but that's okay with me. I don't mind how often you bother Frank. But I would also suggest that you go to the STS annual coding workshop, especially this year, that you send your coders, and preferably that you go as well, because this is the year that we're going to start teaching ICD-10 coding. And ICD-10 coding, if you're at a Mayo Clinic or a Cleveland Clinic or a Hopkins, you don't have to bother, right? Because the big brother is there, they're going to do that for you. But if you're at a smaller hospital or in practice with yourself or with a multi-specialty group, this is going to be critical for you to know and for your coders to know, and you need to educate yourself on that. So, mission accomplished, somewhat entertaining. So let's just go through this again. Wood, boring. Baumgartner, boring. Naunheim, entertaining. All in favor, say aye. Aye. Thank you.